I would like to thank you for the opportunity to present our work here today. We have now a financial relationship to this class. Pain management in the immediate postoperative period has been concerned since early times. Laparoscopic surgery is not exception. Despite the minimal tension on the incision resulting in significantly lowered pain levels, research has begun to minimize postoperative pain after laparoscopic surgery as early as late 19th. This was initially due to increased patient comfort and earlier discharge and later ambulatory surgery. Ambulatory laparoscopic surgery series have been reported as early as 1997. Since then, many studies have been published concerning pain management following laparoscopy. Many agree that adequate pain management is the key of successful ambulatory laparoscopic surgery. And there are a lot of studies published for pain management procedure ranging from irrigation of peritoneum local anesthetic to ultrasound-guided nerve blocks. Why did we do this study? First of all, ambulatory laparoscopic is not practiced at our institution. Due to the legal status of our patient population who are military personnel or undergoing abdominal operation are given a minimum 20 days of leave before resume active duty. We are not very keen on early discharge patient. We are more concerned on patient comfort and have experienced sporadic case of respiratory depression due to opioids in the post-anesthesia care unit. We have observed patients experienced more pain after heart, especially after extensive manipulation of the crura. Considering the abundance of the vagal efferent at the crura, we want to see if injecting local anesthetics have an effect on pain. Due to regulation in our department, any patient undergoing abdominal operation is admitted to surgical post-anesthesia care unit 40 hours, 24 hours. Our standard analgesic regimes consist of petidine 50 milligram and tenoxicam 20 milligrams times 2 unless the requirement is higher. 50 patients were included in our studies between February 2007 and March 2009. Each were given a unique identifier and analgesics were randomly assigned to create control and study groups, each consisting 25 by a third party personnel. We choose to perform a prospective, randomized, double-blind trial to prevent any bias. Patients, surgeons, and post-anesthesia care unit personnel were blind. The patients are given total intravenous anesthesia. 20 milligram of tenoxicam was administered just prior to extubation. After admittance to the post-anesthesia care unit, Pain was assessed by visual analog pain scale on scale of 1 to 10 at 1, 4, 8, 12, and 24 hours. Analgesics were administered as needed. A 5 mm Jackson Pratt drain was placed and removed at 24 hours. 1 mm of bupivacaine or saline was injected at the superior and inferior portions at each crura at the suture sites, totaling 4 millimeters. We modified and used a length injection tip of 40 centimeters total length, which allowed us to reach crura through existing ports. I'm sorry, my codec. Okay. The visual analog pain scale scores were assessed by t-test. Although the study group had lower mean scores at all measurements, the difference were significant at 4, 8, and 12 hours. Our patient received 20 milligrams of tenoxicam at the 4th hour in the post-anesthesia care unit. The need for a second dose in the first 24 hours were recorded. Although less patients need a second dose in the study group, the difference was not found to be significant by chi-square test. Opioids were not routinely administered and given if non-steroids failed to relieve the pain. The need for opioids were significantly lower in the study group. We believe that experimental expectancy to be very influential bias in the result of study. To prevent occurrence, we choose to perform a prospective randomized double-blind study. Our results have demonstrated less pain in the study group, as shown with both visual analog score pain analysis and opioid requirements. This results a more comfortable, immediate postoperative period for our patient. Injection of bupivacaine may be beneficial, augmenting pain control for ambulatory laparoscopic Nissen fundoplication. We have searched PubMed but failed not to find series of similar approach. Our numbers are low and not many studies exist to verify our study findings. Larger series by different teams and need to confirm our results. If verified, this technique may be augmented cost effectively by reducing admission due to pain ambulatory laparoscopic Nissen fundoplication. Thank you, sir.